You don't have to be sick to visit the doctor. In fact, the best time to visit your primary care physician is when you're feeling well. Even when you're young, preventive care can help ward off many health problems. On this week's Health Talk, an internist will join us to discuss the importance of preventive health care for people under 50. So stay tuned for this important and informative show. Health Talk is up next. Hi, I'm Dr. Eric Mazur. Today we're going to discuss preventive health care for people under the age of 50. My guest is Dr. Michael Schwartz. He's an internist with Darien Primary and Specialty Care. And Michael, it's really great to see you again. It's been a while since we've seen each other.
It has. Thank you for having me.
And I'm so happy to see you. So tell us, we're talking about preventive care for young people. My kids are young. My sons are young. I don't think they know how to see a doctor. And I yell at them all the time. So tell me, there is real preventive care for people under 50. What should they be doing?
There is. My philosophy has always been find it and fix it before it breaks. And in every age group, there are things that could occur. And so what we do is we utilize the preventative visit, the physical exam, as a way to identify problems, address them, so they don't become more serious as we age and go down the road.
And of course, it's, I will talk about cholesterol in a minute, but you can start something at that age that has tremendous consequences later on in terms of preventing disease for you. So tell us, what are the things you look for in the young people? What kinds of things are you trying to prevent?
What I first do is I try to educate my younger patients because, yes, we're all going to be hopefully in our 50s, 60s, 70s, and beyond. And when I was growing up, we always learned that Grandpa worked till he was 65 and died at 70, and we used to say, what a nice long life. And today when you have people in their 80s going to work every day, it's a different world. So we have to start earlier to identify issues and address them. And you mentioned cholesterol. Who would have thought years ago we would look to see, to look for elevated cholesterol in a 20-year-old? But we do that now because that is a major risk factor. And if we don't address it and they go from 20 to 50 with elevated cholesterol, well, they're going to be at a higher risk for depositing plaque on all their arteries.
And by 50, you've already started the process.
You have, and it's never too late. It's never too late to have a preventative exam, and it's never too late to start to address medical problems. But again, the earlier we identify them, then the easier it is that we could treat them and fix them.
I'll tell a personal story. High cholesterol runs in my family. My father had my father was a smoker, but he also had his first heart attack in his 50s, in his mid-50s. And they had another one in his 60s. He ended up dying of something else. But he had unquestionable cardiovascular disease, as did my mother, who had high cholesterol. And when I was late 30s or 40, I went to a doc here in Norwalk. We both remember him, Dr. Joe Andrews.
Sure. And
I'm just going to give him a little advertisement because I think he was a great doc. And he said, Eric, although the evidence isn't strong, that was many years ago, he said, why don't we put you on one of the statins? And I have been on a statin ever since I was 40, and I've never had any kind of cardiovascular issue, and I'm now in my early 70s. So I had a stroke. So, that really convinced me, and I thank him. He was ahead of his time, but I think that we are realizing to intervene younger and younger, and statins are wonderful drugs.
They are, and there's so many studies now that look at primary and secondary prevention. And I'm a proponent, again, of finding it and fixing it. So if we identify somebody who has maybe a mildly elevated cholesterol, we'll do the usual things. Low cholesterol diet, exercise, reduce the risk factors that could cause problems like cigarette smoking, obesity, things like that. But ultimately, they may need medication down the road, and we're going to follow those individuals through their 20s and through their 30s and make some decisions which can very well impact them down the road.
And I know diet and lifestyle is sort of always the first thing you put out there for blood pressure and cholesterol. But on the other hand, I think it's very hard for a lot of people to meet those expectations. And then I had a friend who was a famous lipidologist who told me that in some of the early studies, at least, a large percentage of people are not diet sensitive to their cholesterol. They can do all that and their cholesterol still stays up, and they should avail themselves of these medications. They're miracle drugs, in my mind.
I've had patients who are 350 pounds and have cholesterols that are probably better than you and I. And I have other patients who are 100 pounds soaking wet and their cholesterols are through the roof. There is a genetic component.
Absolutely.
And I tell patients, don't beat yourself up, because you could be doing all the right things. Your blood pressure could still be high. You could still have high cholesterol. You could still develop diabetes. There are things that we just don't have the ability to control yet, but we could impact them.
Well, I think that's such an important point. And you know, it's not a failure in you if your cholesterol is high or if your blood pressure is high. And as you said, this is almost 2021. We have great medicines to address these issues. And we talk about people under 50. When would you ideally like to pick up these folks and start at least evaluating them and following them? You know, what age?
Well, I'd like to evaluate them, you know, above the age of 18. It doesn't necessarily mean I'm going to start a statin. You know, what you want to do is you want to try all of those other things before you're going to put a 25-year-old on a medication for the rest of their lives. And when I say the rest of their lives, you have to understand that in 5 years or 10 years, there may be a magic pill that alters our genetic makeup and all of a sudden we all have perfect cholesterol, but that's not available yet. I also tell patients that they got to live their lives, because what happens is, you know, they try to maintain this perfect low cholesterol diet and they get close to getting a good reading and they say, doctor, there's nothing more I could do. I don't have cheeseburgers. I don't have, you know, the eggs, the shellfish. And I say, why not? And they go, well, you told me my cholesterol's high. I said, you know what? You got to have an occasional cheeseburger. You got to have an occasional shrimp. If not, what's the purpose of living? So we incorporate all aspects to come up with a plan.
Yeah, and you know, again, as you said, so much of it is genetically determined. Now, again, I don't want to underestimate the value of exercise, good diet, and all that. But as you said, we live our lives. Food is an important part of the way we celebrate life. It's the way we socialize. It's the way we interact. And you don't want to destroy your life in the process of saving it. And as you said, you be reasonable, but we do have ways we can handle these things. What other things do you look for in the young patients? What are the diseases that you're most, we mentioned hypercholesterol, which is so common, but what are some of the other ones you look at?
Well, one of the things, for example, in a male between the ages of 20 and 40, those are the most common age where men could get testicular cancers. So I start to educate my patients right when they're 18 years old and say, you need to do a self-exam every month. And if you feel anything that feels hard like a rock, a BB, a marble, you come in and let us check that out. Strangely enough, we do have testicular cancers in people over the age of 40. So that's something that really needs to continue throughout a male's life.
Pat you on the back. You know I'm an oncologist, and I just have always felt that that's an underappreciated problem of particularly even young men. We don't know how to examine our own testes. I'd even argue that a lot of the doctors don't even know how to examine testes properly. And there are lots of stuff to feel down there that is not cancer. So you got to get used to feeling the epididymis and feeling the varicocele and maybe even feeling the hernia that isn't cancer. So I really want to congratulate you on that, because I think that's, this is a very curable cancer in most instances, but why not catch it earlier and make it, and spare yourself some of the morbidity of therapy for advanced cancer. I think that's great, Michael.
Thank you. We also do. I also do something different with prostate, for example. The recommendations say 50 years old, and even with risk factors, and maybe 45 if you're African American, and then they throw in a family history and things. I start every male who's 40 years old on a prostate exam, both digital and a PSA. And unfortunately, or fortunately, my last 6 prostate cancer diagnoses have been in men in their 40s. One being age 41, and it already was metastatic.
And it tends to be more behave worse in the younger age group.
It does. This gentleman, I mean, I think that if I hadn't checked him till the guidelines suggested age 50, I'm not sure a male 41 years old with metastatic prostate cancer would even be around at age 50 to have the discussion. Right. So I find it's very important. I find a lot of physicians, unfortunately, don't do the digital exam. And it's a combination of both a digital exam and using the PSA to come up with, you know, an idea if there's something going on.
Well, I think, and you know, you can speak to it more than I. People are rushed. The appointments are attenuated. The administrators want you to see the patient every 15 minutes, and to do a nice, gentle digital and have the patient comfortable and talk about it, I think takes some time.
It's also about educating the patients. Unfortunately, patients think that a physical exam is, I'm going to bring in my list of my 27 problems and we're going to address them. It is a preventative care exam. And the time I allocate is very focused because I'm trying to find those things that are hopefully going to, you know, prevent an early death or morbidity, mortality. And if I have the time to do it, which I always make the time, I find things and I address them with the patient and I educate the patient. Education is so important. If they know what to look for and they know their body, they're going to help us. They're going to tell us what's going on and allow us to keep them healthy.
And how about things like diabetes, blood pressure? I mean, I would think that's part of the general screening at all age groups.
Yeah, so we start off with the vital signs, obviously. Blood pressure, heart rate. We do a height and weight because we're looking for a BMI, body mass index, which we ideally like to be, you know, below 30. I mean, we do find the majority of our patients are above that, which is meets the criteria of obesity. And
I certainly, that's an aspirational goal for me on
me too.
a regular basis.
But once you hit that, then it goes along with risk factors. You know, it becomes another risk factor for heart disease and diabetes and things like that. So we do that. And then I do an EKG on everybody. And the reason I do is, you know, God forbid a 33-year-old ends up in the emergency room with chest pain and has an abnormal looking EKG. They call my office and they say, hey, Dr. Schwartz, do you have an old EKG? And I go, absolutely. And it saves a lot of extra work for the emergency room and other physicians just to have that comparison. And, you know, there's always an insurance issue, is something like that covered? But generally there's a diagnosis. Somebody might be athletic, they have a low heart rate. That will cover it. Somebody's blood pressure may be a little borderline. So there are ways that we could order a test which makes sense, but just not ordering every test there is out there. And then we do a urine analysis, which is helpful. Could look for blood and protein and things like that. And then, like I say, I do an exam. It kind of starts at the head, goes down to the tail, and I examine pretty much every aspect of the body.
And I think, again, it's important to emphasize, this is not necessarily just for 60-year-olds. This is for someone who's in their 20s and 30s. Well, can you tell me, we've got less than a minute left. Do you want to give an example of something? You just mentioned one, the prostate cancer you picked up early. Maybe some other patients that you picked up something early that had a major impact on their life?
Sure. I mean, going back to the testicular cancer, I actually had two gentlemen that I did an exam in the testicular area, and one, it felt like a golf ball, and I thought he had maybe a surgery with an implant, and the other was the size of a softball. And both patients were not going to mention this to me. It was just because I did the exam. And I said, how long is this going on? And one said about 6 months, and the other said about a year. But they were not going to actually volunteer that information. But because I took the time to look, we identified it. Both had testicular cancer, and both did quite well after, obviously, surgical removal.
That's great. That's great. I remember seeing a patient. I was seeing the patient for oncology. We just running out of time, but they had a mole on there. I looked at their skin. They had a nasty-looking mole on their back, and they turned out to have a melanoma. Just these simple things that we do, but that can have such major impacts on our patients.
Absolutely.
Oh, that's great. Thank you. You do a good job for your patients. I'm really glad to hear that. Unfortunately, we are out of time for now. I want to thank my guest, Dr. Michael Schwartz, for joining me on Health Talk today and discussing this very important topic. And thank you for watching. Please share your questions and comments with us at Health Talk at newvancehealth.org. Stay well and see your doctor.
Coronavirus isn't over. We still have to slow the spread and do our part. Let's wear face masks in public. Stay 6 feet or more from others. Follow state and local guidelines. Wash our hands frequently and stay home when we feel safe. For ourselves, for our loved ones, for our future. Let's move forward together. Learn more at coronavirus.gov.
145 over 92.
180 over 111.
182 over 100. And I had a heart attack and a cardiac arrest, and then a stroke.
Your blood pressure numbers could change your life.
A lot of people don't understand, including myself, I didn't, now I do, the impact of having a stroke.
My memory is shot.
When I woke up, I couldn't speak.
If I would have followed a treatment plan, I would not be in this situation.
It's a tough journey.
Lowering your high blood pressure could save you from a heart attack or stroke. If you've stopped your treatment plan, restart it or talk to your doctor about creating one that works better for you. Start taking the right steps at manageyourbp.org.
It's a new life, but I'm gonna make it better. Coming back. Ask your doctor, check your blood pressure.
If you're over 50, especially when you're over 50, your risk for a number of health issues rises substantially. If you're wondering which preventative health issues you should address as you go through middle age, please stay tuned to this week's Health Talk. Our guest is a primary care physician who will discuss preventative health care for people over the age of 50. So stay tuned for this informative and important show. Health Talk is up next. Hi, I'm Dr. Eric Mazer. Today we're going to discuss preventive health care for people over the age of 50. Our guest is Dr. Michael Schwartz. He's an internist with Darien Primary and Specialty Care. And Michael, it's great to have you here. It's great to see you again. Great to have you on the show.
Thank you for having me.
So this is your life, taking care of people under and over 50. 50 is getting to that age where things start to happen. So what's your approach to people sort of square in their middle age in terms of preventative health care?
Well, hopefully they've been my patient for a long time, so we've been together through their maybe 20s, 30s, and 40s.
So you've been doing the preventative care of their 20s and 30s.
So I've started already the process, but things change in each age group, whether you're in your 20s, you're in your 50s, or in your 70s. When we get into our 50s, which is now considered middle age, which I find a little bit surprising because when you think of being 50 or 60, it doesn't seem that old anymore, but growing up, obviously, it was a different case.
As someone who just recently hit 70, that doesn't feel that old to me either. It's sort of shocking how young it feels.
Because there's so many guidelines out there that look at people in their 70s and 80s and 90s and say, stop doing those tests. And yet, I see them living, wonderful lives, and why would I not order preventative health care regardless of their age?
That's a really good topic at some point, is that, as you said, as old becomes older and older, preventative care starts to extends into what we used to think of as old age, because you're looking 10, 15 years down the road.
Absolutely. I mean, when you think of somebody 80 today, and you think of when we were growing up, somebody 80, you're like, wow, they've had a really long life. But I don't look at it that way anymore, because I have people well into their 90s who are living very active lives. So we do start in the 50s with some of preventative care. For example, we talk about colonoscopies. I'm very into preventative health care. I believe in find it, fix it before it breaks. So when we have somebody who's 50, I emphasize the need for a colonoscopy, which is both diagnostic and therapeutic, meaning you find a polyp, you take it out, in 8 to 10 years, that polyp doesn't become cancer, and now you're not in trouble down the road.
Michael, I know some of the societies have even recommended scooting the age of first colonoscopy back to 45. Is that something you're doing in your practice? Is that something you support?
I'm doing that in certain circumstances. The problem is the American Cancer Society came out and said now we should be doing all the colonoscopies age 45. And at the same time, there's other recommendations that instead of doing it every 5 years, it should be every 10 years. So it really is very confusing to the primary care provider. The 45 makes sense because when I was in medical school, I always learned that from the time a polyp started to grow to when it became cancer, not all polyps obviously become cancer, it took 8 to 10 years.
But stop for the folks at home. A lot of people may not be aware of that theory, and it's really essential to understand why colonoscopy is so effective. And that is that most colon cancers, we believe, start as polyps that are benign. and then progress over a period of 10 years or so to a cancer that we can detect. But if we take polyps out, you prevent the cancer. Now, that's not, as you said, not all polyps, but just, I think it's people may not understand that, and I think that's why colonoscopy among physicians has really become our screening test of choice, you know, better than blood in the stool or some of the genetic. We like to catch that at the polyp stage before it becomes cancer.
Well, there are other tests out there, and people will bring up, you know, the Cologuard test, yeah, and the fecal cards and things. And I always say that in the end of the day, the colonoscopy, being both diagnostic and therapeutic, means you're not only able to find it, you're able to fix it. Yeah. And that's why at 50, I think it's important. Now, going back to the 40s again, there are patients in their 40s with colon cancer. It's not very common, but when it happens, it's not necessarily a good outcome because we don't look for it. So I would
even point out family history. If someone's got a first-degree relative with a colon cancer, first-degree mother, father, brother, sister with a colon cancer in their 40s or early 50s, I think most people recommend a colonoscopy 10 years before the age at which that was diagnosed.
Absolutely.
Well, things can start quite young in
So
family.
we start at age 40 if anybody has that kind of family history, or 10 years earlier than the earliest diagnosis. So if mom had colon cancer at age 47, we're going to start you at 37. Yeah. The issue is with insurance companies. I would love to be able to recommend that every one of my 45-year-olds starts the colon process, but if they don't have risk factors, then unfortunately insurance is not going to pay for it, and that's where it gets a little bit dicey. Yeah. The recommendations, the guidelines, versus doing what's right versus doing what's being paid for, and that's where it gets difficult.
I can see that as a problem. But because colonoscopy is just so effective, we shouldn't be losing most people to colon cancer in this day and age if we did the screening as recommended. And I know that the compliance, I don't know the exact numbers, but it's certainly not better than 60 or 70%, is it, with that recommendation?
You know, in my patient population...
Not yours, I mean...
In general, yes. My patient population is better because I really take the time to explain the benefits, the pros, the cons, the risks, the side effects. And once a patient hears that, most of my patients will say, let's do it. And I think that's wonderful.
I mean, I've certainly done it, and I would recommend it too. It's just not that bad a procedure. So go ahead. We spent a lot of time with colon cancer, but that's a big deal. What are some of the other ones that things you think about in the patients over 50?
So starting earlier, I mean, we look at, for example, the yearly physical exam that we're talking about, because that gives us an opportunity to do some of these things and find some other issues that we may want to act on. But for example, mammograms and PAPs, this starts way earlier and it continues through the 50s, through the 60s, and so on and so forth. As people get older, women get older and become peri and postmenopausal, we recommend bone density scans. This is really important because if I could, again, identify a woman who's 55 with weakening bones impacted at that age, at 75 when they slip on the rug or the water on the floor, they don't break a hip.
Yeah,
and
the
as
point
you
is
know,
we could do stuff about this.
We could.
There are things that we could do to make the bones stronger. Go ahead. I don't want to take the words out of your mouth.
No,
but you're
right.
right. These are things that we can help. You treat now, and then you delay or prevent the consequences later.
Yeah, and when we do, and a person falls at 75, they go, oh, doggone it, I fell, and they get up and they go on with their lives. A fracture in an older folk is a dangerous thing, and there's a good percentage of people who actually never recover. Yeah. And this is where it gets a little bit more interesting because we start to screen men at a certain age, usually over 70 or 75, and we'll order bone densities as well.
I've heard that that's one of the least performed things that should be done, as an older man with a fracture should have bone density. And it's rarely done. Something to think about out there, men, because again, you can have osteoporosis or you can have other diseases. The multiple myeloma can present with osteoporosis.
I order it on a number of patients, and oftentimes because we don't have a diagnosis, and that's the problem. We really need to create a diagnosis for men to allow us to order that where insurance will cover it, because it's so important. It's not just women who fall and break hips, it's men who break hips, and again, they don't do much better than the women long term after a hip fracture at that age.
I've been through this with my own family, and I will say, you know, and I looked at the statistics. I think about 50% of the elderly, maybe it's over 75 or 80, who fracture their hip don't survive a year afterwards. And that was true for my mother. She fractured her hip, and that was the beginning of the end. She had other problems, but the hip fracture is what directly attributed to her or death.
Sure.
So this is the common reality. Hip fracture is a big deal when you're old.
Absolutely.
And it results in a lot of problems. Okay, other thing, how about smoking? Cancer screening?
Right, so smoking is very interesting because there is a good studies and literature that suggests that if you were a smoker for more than 30 pack years, meaning 1 pack times 30 years or 2 packs times 15, still smoke or quit within the last 15 years and are older than a certain age group, you should have a yearly low dose radiation CAT scan to look for nodules that could become cancer down the road. This screening has been wonderful. It's almost like having a mammogram of the lungs. You find something, and based on criteria, you go, you know, it looks okay, but why don't we repeat that in a year? Or it looks a little suspicious, let's repeat it in 6 months. Or wait a second, we need to bring you back and do more studies. This should reduce the risk of lung cancer significantly in those patients who are a higher risk group. And it's hard sometimes to get them to do the test, but I have patients on a yearly schedule and they go every year, and we've identified some lung cancers which have been easily treated and did not become a problem.
And you know, we've been talking a lot in the COVID era about science. There is really good science that supports the value of these screening tests, the low dose radiation CT of the lung in smokers, to prove that it saves lives. We know it saves lives. We know mammograms saves lives. There are data out there that we know that controlling cholesterol and high blood pressure saves lives, as well as controlling blood sugar. There's so much data out there for what we can do preventively for patients.
And these are all things we discuss at the physical. In addition, we talk about immunizations.
Oh, that's a great point. Go ahead.
So starting at 65, for example, unless there are other reasons for it, we start at 65 with the first pneumonia shot called Prevnar, and a year later we follow with something called Pneumovax. And once you've received those 2 shots, with exceptions, you're pretty much done. Now, are you protected against every type of pneumonia? Absolutely not. But it's the more virulent, the more dangerous kinds of pneumonia, the ones that could have you end up in a hospital in the intensive care unit. So that, I think, is important, along with the yearly flu shot, which should kind of be all ages.
Absolutely.
And then we talk about the Shingle Shot, which is obviously very popular these days, which we start at age 50. And that is followed with 1 shot, another one 2 months later. And it reduces the risk of shingles, probably, depending on age, anywhere from 80 to 95%.
Which is a miserable disease.
It's not a good disease.
And it can have it doesn't generally kill you, but it can have long-term painful consequences. So it's absolutely it's a miraculous vaccine. And then you've got the regular vaccines too. You know, the diphtheria, pertussis, tetanus vaccines, where people we think about them in the kids and doing it every 10 years, but then you get into the older age and people stop thinking about those vaccinations, and they absolutely should be kept up.
Yes, no, and we do, and that's the importance of a screening exam. And as somebody goes into their Medicare years, they are able to get what's called an annual wellness visit. Now, this is not really a physical exam. This is more of a Q&A, but it's extremely beneficial and helpful. It allows us to go through all of their history and allows us to catch up with all of those things that they might have not had. So it's a great screening tool to see what doctors they need to see, what exams, what blood work they need to do, what immunizations or vaccines they need. So it gives us that opportunity to identify and perhaps reduce their risk of getting sick down the road.
But there is just, you're articulating so much that can be done, and I think so much important that don't wait till you get sick. When you're well, it's the right time to see you. It's the right time to go through all this stuff. And boy, science has just generated these wonderful drugs and approaches and things that we can do. I think it's just great. That's really good news, Michael. Thank you so much for giving us all this information and so doing it so enthusiastically. I thank you from your patient standpoint. Unfortunately, we have run out of time. I want to thank my wonderful guest, Dr. Michael Schwartz, for joining me on Health Talk today and discussing this so important topic. And thank you for watching. Please share your questions and comments about our show with us at healthtalk@nuvancehealth.org. Again, I want to thank my guest. Thank you for watching. Stay well and see your doctor when you're well.
fight against coronavirus isn't over. We still have to slow the spread. Learn more at coronavirus.gov.